Okay, mouse accused.
Yeah, we can start now.
Good morning, everyone. Today I will be presenting Phakic IOLs. What are the Phakic IOLs? These are the lenses implanted in eye permanently without removing the natural lenses. They are used to correct the refractive errors in the eye's focusing power. Its advantage over the other lens-based refractive procedures, like refractive lens exchange with monofocal or multifocal lens, was its property of preserving accommodation in young patients. Limitations of laser refractive surgeries like high metropia, irreversibility, and permanent damage to cornea. These can be avoided. So the types of phakic IOLs: posterior chamber like implantable contact lens, phakic refractive lenses; anterior chamber iris fixated like artisan or veriflex; anterior chamber angle supported like Acrisoft cachet. These are the designs. Anterior chamber angle supported phakic IOLs. The concept of using these angle supported phakic IOLs was introduced in 1953 by Stampelli and later Barrett in 1959. So as we can see, there are the 4-point fixation haptics and optic of 6 mm. In 1889, the clear lens extraction for correction of myopia, known as Fukala surgery, this was abandoned due to the complications. In 1950s, there was correcting myopia by inserting concave lens into the phakic eye. In 1988, BICOP, the anterior chamber angle fixed IOL, was introduced. In mid-1980s, posterior chamber phakic IOLs. This was invented by Fedorov. In 1991, Artisan, the worst iris claw lens. Posterior chamber phakic IOLs. It had a collar button, a mushroom configuration. It was a silicone IOL, 8 mm in size, 3.2 mm optic with a concave surface projecting out of the pupil. This lens is fixated to sulcus and is mobile. Hence, it corrects the spherical and cylindrical powers. Complications. There are few complications like lens touch with cataract formation, pupillary block glaucoma, endothelial touch, lens decentration, and iridocyclitis. Present generation of PC phakic IOL called implantable contact lens, which is implantable Collamer lens. The material used is Collamer, 1% porcelain, Collamer, and 99% hydroxyethyl methacrylate Collamer. The less used phakic refractive lens, which is floating lens in PC. These are only designed for spherical powers, not available in cylinders. Anterior chamber iris fixated phakic IOLs. The claw holds the mid-periphery of iris, least distorting pupil contour and movements. It was non-flexible PMMA lens that had to be inserted through 5 mm incision, which has to be closed with sutures, having unpredictable effect on the corneal astigmatism. Peripheral iridectomy was must. Flexible lens version was introduced to reduce the size to 3 mm and make incision stitches with predictable astigmatism called artiflex or veriflex. Anterior chamber angle supported phakic IOLs. They were designed on the principle of angle supported Kelman IOL. They had high incidence of endothelial cell loss, chronic low-grade uveitis, hyphema, and glaucoma. These three come under the UGS syndrome, the complication of intraocular shafting from intraocular lens implant leading to spectrum of iris transillumination defect. The other complications were pupil ovalization, peripheral anterior synecdoche, and cataract few times. So in preoperative evaluation, one should see the following data is being filled. Age should be 21 years or greater. Refractive stability should be less than 0.5 diopter change in 1 year. Clear crystalline lens. Mesophilic pupil size less than 6 mm. ACD should be greater than or equal to 3 mm for iris claw lens and angle supported pools, 2.5 mm for posterior chamber intraocular lenses. High refractive errors. ICL allows correction of powering ranging from minus 18 diopter to minus 3 diopter, and plus 3 diopter to minus 21.5 diopter in half diopter increments. A minimum endothelial cell density of more than or equal to 3500 millimeter square at 21-year-old, more than or equal to 2800 cells per millimeter at 31-year-old, more than or equal to 2200 cells millimeter at 41-year-old, more than or equal to 2000 cells at millimeter square at 45 years of age.
What is, where did you find these figures?
Sir, I have found it in the article, AIOC article.
And this was the minimum required quantity of endothelial cells.
Yes, according to age, it varies.
Okay, because we don't see about like this 3,500 specular count in most of the patients. Average is
Okay,
like 2,800 to 3,000 only that we get.
okay, sir.
Okay.
Absence of ocular morbidities, including uveitis, glaucoma, cataract, and risk of retinal detachment. Then the corneal topographic abnormalities, eyes with a thinness pachymetry lower than 475 microns, calculated residual stromal bed of 280 microns or less following keratorefractive procedures, corneal phakic disorders, including keratoconus and pellicidal marginal degeneration, that are contraindicated for keratorefractive surgeries. Preoperative evaluation and workup, visual acuity corrected and uncorrected for near and distance. Cycloplegic refraction should be stable for minimum 1 year prior to the surgery. Cycloplegic refraction is imperative to reveal the pseudomyopia secondary to spasm of accommodation. Increase in IOP is a contraindication for phakic IOL implantation. On slit lamp examination, one should assess the adnexa, ocular surface, tear film, and crystalline lens. Blepharitis and MGD should be treated for reducing postoperative inflammation and dry eye. Fuchs endothelial dystrophy is a contraindication for phakic IOL implantation. One should rule out presence of glaucoma, ocular inflammation, and cataract formation. High hyperope should be carefully evaluated for narrow intraocular environment. Quantitative and qualitative evaluation of tear film function, dilated fundus evaluation, particularly in myopes, having increased risk of peripheral RD. Risk of RD following phakic IOL implantation is 0.9%. Rule out the zonular defect, which can lead to vitreous luxation and decentration of the posterior chamber phakic IOLs. Corneal topography. It is used to rule out the corneal ectatic disorder, assess the disease stability after cross-linking process, measure the anterior chamber depth and axis, magnitude of the corneal astigmatism. Generally used system, slit scanning, under which OPSCAN, Bosch and Lomb, New York, and skin flux imaging, where Pentacam, Oculus, Germany, etc. are used. High-speed anterior segment OCT, like Visante, Karl, Germany. In this image, we can see that there are the light color, which indicates that this is the flat meridian, not the steep one. Specular microscopy. This helps to assess the status of corneal endothelium. Minimum endothelial count indicated is 2500 cells per millimeter square. Pupil diameter, useful for assessment of post-op glare and halos. If the pupil size of 6 mm or more than 6 mm is there, then the patient can have post-op glare and halos. Ocular dominance. This is tested for patient
How do
undergoing
you
monovision
measure the
correction.
pupil diameter?
Sir, it can be measured manually or um,
Manually, how?
uh, on the slit lamp, sir, we can set it,
How can you measure scotopic pupil size on slit lamp? Yes, anyone else? Kishan, Kishan,
Sir,
Sir, on pentacam
Sir
vision
is
method.
saying pupillography.
One option is pupillography, which can be done on pentacam or cirrus that we have. Any other device that can measure?
So we can measure with the direct ophthalmoscope also.
Direct ophthalmoscope. How?
With the illumination, so a small illumination size.
But it will. How will it give scotopic pupil size? We want to measure the scotopic pupil size. This 6 millimeter and above is pertaining to the scotopic pupil size, not the mesopic or photopic. Anything
So
else?
IOL muster can be.
Yeah, Almaster, yeah, it has, but it doesn't measure the scotopic again. Any other device? We have autorefractometers also, which measure the pupil size. Okay,
Yes, sir.
so you can check the UV autorefractometer, it gives pupil size.
Yes.
Okay, but
Yes, sir.
I think easiest is to use cirrus because it gives all mesopic, photopic as well as scotopic size. Okay, go ahead.
Ocular dominance tested for patients undergoing monovision correction. Monovision is a method of presbyopia correction where the dominant eye is corrected for distance vision and non-dominant eye for the near vision. Contrast sensitivity denotes the relationship between optical efficiency of eye and minimal retinal threshold for pattern detection. Measurement of white to white diameter. Phakic intraocular lens was designed so that its haptic rests horizontally on the ciliary sulcus. Length of intraocular lens should be equal to horizontal sulcus diameter. Calculation of lens power. ICL calculation and implantation software allows the calculation of the spherical and cylinder power. Length and generates the ICL implantation diagram as shown. So IOL power calculation in anterior chamber and posterior chamber IOL. These are the formulas, Van der Heij formula and Binghorst formula. Under ACIOL, patient's refraction keratometry and anterior chamber depth. These are the measures used for the formula. And patient's spectacle refraction, corneal power, and the anterior chamber depth and angle to angle distance. These are used in the posterior chamber intraocular lenses. ACD is measured from the corneal apex to anterior surface of crystalline lens and is used to calculate the effective lens position in PCIs by subtracting distance between the posterior intraocular lens and the crystalline lens from the ACD. The effective lens position is typically 0.8 mm in artisan. White-to-white measurement with an IOL master or caliper can be used to estimate the angle-to-angle distance. Corneal power is calculated using keratometry or topography to measure the curvature of the cornea. Anterior chamber depth, geometry of the chamber and opening of the
Go,
iridocorneal angle.
go to the previous slide. What is this IL power calculation suddenly in the Phakic IL?
Sorry, sir.
What is this slide to do with the Phakic ILs?
So actually, white to white measurement is important in the calculation. So it is.
No, no. This slide is regarding IL power calculation, no?
Yes, sir.
Not Phakic IL power calculation.
Sir, actually, it is the fake.
Okay. Go to the next slide.
The geometry of the chamber and opening of the iridocorneal angle are critical issues to ensure the safe implantation. Lens vault, it is ideal 250 to 750 mm and it can be measured using anterior segment OCT. Peripheral iridotomy, it is performed 1 to 2 weeks before the surgery to provide an outlet for aqueous flow around the lens. It should be sufficient wide, minimum 500 microns, superiorly at 11 to 1 o'clock, and away from the haptic placements. Thorough preoperative evaluation allows the selection of appropriate size implants, reducing risk of complications like glaucoma or cataract. So now we will be seeing how the implantation is been done.
We have our own videos of phakic IOL implantation. Why do you have to show this? Go to the next slide.
Yes. So postoperative protocols. Antibiotic steroid combination is given 6 times daily in operated eye for 1 week. Low-dose steroid drops are given for 2 or more weeks. Topical NSAIDs eye drops are instilled for 1 month. Postoperative evaluation, this should be repeated on the first and the seventh postoperative day. Complete ophthalmological evaluation,
We
intraocular
don't
pressure measurement.
we don't use this protocol. We give antibiotic steroid combination 4 times for a week, and then we quickly taper it off in next 10 days, and then we give Nepafenac. So we don't give low dose steroid drops.
Okay, sir.
Next.
Complications of the phakic IOL and their management. Posterior chamber phakic IOLs, intra-op complications. Careful loading of the ICL is in correct orientation onto its cartridge is most crucial step to ensure the appropriate unfolding of the intercontact lenses in the anterior chamber. Dropping, chipping, then reversing. Opening of the ICL in reverse orientation is dreaded complication. Causes faulty loading, incorrect orientation. 3 holes of the ICL not being aligned properly. Unequal distribution of OVD in the anterior chamber, resulting in flipping of the ICL while injecting it. Slow injection of ICL in an anterior chamber should be performed to assess the direction of the opening. Inverted ICL can lead to central lens touch, causing the cataract formation if stayed in that position for a long time. Clinical assessment of the holes in the haptic for orientation of ICL in the post-op cases can be done by anterior-segment OCD. Reverse ICL is an indication for ICL explant followed by injecting the same or new ICL. Early postoperative complications. Raised intraocular pressure and glaucoma. IOP raise in few cases occurs due to retained OVD or steroid response in the steroid responders. Infrequent blockage of the peripheral iridectomy in an immediate postoperative period needs a short course of anti-glaucoma medication. Pigment dispersion can be caused by preoperative laser PI or constant friction of ICL with posterior pigment layer of iris in case of high wall. uveitis, surface of these ICLs attract deposition of fibronectin that provides an immune privilege status to iolin eye. Visual dysfunction in the form of glare, halo, and night vision problems can be complication. Endophthalmitis risk is 0.016% and toxic anterior segment syndrome. Late postoperative complications. Patients with low operative wall develop anterior subcapsular cataract, 6 to 7% in 7 years and 50% in 10 years follow. Endothelial cell loss and corneal decompensation. These are the major concerns for angle fixated and iris fixated phakic IOLs.
Iris
Posterior
fixated
segment.
and the angle fixated IOLs are long gone now. Nobody uses these IOLs. They are not even available. And
Posterior
the
segment.
incidence of subcapsular cataract is too high. Where is this from, this data?
Uh, so that AIOS document is there.
No, any reference to that? Because this is too high. We haven't seen any such. Because we see hardly less than 1% patient even after 10 years developing cataract. So I think this quoted figures are wrong. 50% in 10 years follow-up is too high. That means I might have used maybe say 600, 700 lenses. I should have done 350 cataracts by this time. I have hardly done one. So I think these figures are wrong. You should have
Exactly.
references when you quote these figures. Next.
Posterior segment complications. Myopic patients are at increased risk of RD. Any intraocular surgery may lead to further add-on risk. Recent advances. Implanted collagen lens is a single-piece foldable plate haptic posterior chamber implant composed of volage, biologically inert material. Currently available V4 model has stiffer radius of curvature, allowing additional 0.13 to 0.21 mm of anterior vaulting in comparison to earlier designs. These are central hole for aqueous transmission. V4C is currently available model and has central 360 micron hole, the KS aquaport. This allows a lesser disturbance in the aqueous circulation with lower incidence of cataract secondary to metabolic changes. Implantable Phakic contact lens. It is single piece plate haptic implant composed of hybrid hydrophilic acrylic material. The implant has optical diameter of 6.6 mm and affords a myopic correction of -1 diopter to -30 diopter in steps of -0.5 diopter. Hyperopia correction of +1 diopter to +15 diopter in steps of +0.5 diopter. And astigmatism correction of +0.5 to 10 diopter in steps of 0.5 centimeter. Central hole for aqueous transmission. Central 380 micron optic holes allows physiological transmission of aqueous currents with a lower incidence of lens metabolic changes and subsequent cataract formation. The central hole is conical in shape as against the cylindrical configuration of ICL. This allows lower scattering and subsequent loss of the eyepiece. Acryl phakic intraocular lenses. These are the most recent addition to the posterior chamber phakic intraocular lenses. The implant is a single piece plate, haptic hydrophilic acrylic material. The optic size varies from the 4.6.5 mm to 5.50 mm with overall length of 12 to 13.5 mm. It affords the spherical correction of -3.3 diopter to -23 diopter. Thank you.
I think the presentation was okay, not very in detail. And you should focus on what are the recent advances. I think it was picked up from some old this thing. And you should have videos of our own hospital to show the implantation techniques and if there have been any other. There are a lot of videos we have put on the YouTube also. You could have got from there also. Okay. I will
Yes.
share one video and
Yes.
you can tell me how it was done. Okay. What are the
Yes.
share? So this lens we have done in a keratoconus size. So you have not spoken anything about IPCL in keratoconus patients.
Yes.
Anyone else? You can see the video.
Yes.
So this is a 10 diopter cylinder toric IPCL. This is a customized IPCL done in a case of a keratoconus patient after C3R. So what is the indication for doing IPCL in case of a keratoconus? Anyone else? What are the special precautions that you have to consider? पुढे येऊन बोल. कोण अमोघ आहे का? हॅलो. हॅलो. Come closer to the laptop. I can't hear you. So this is a 11 cylinder IPCL which is now being used. When do you do toric IPCL for keratoconus patient?
So when we cannot go ahead with any other practice procedures because of no problem.
Which procedure?
So these flap-based procedures.
That is obvious. Keratoconus. But when do you do
So the
it? So can
thickness.
you do it in all patients of keratoconus? Hmm? What is the expected vision after IPCL implantation in a keratoconus eye? Okay, see, in keratoconus eye, we have to check the spectacle corrected visual acuity. So only if patient has fairly okay spectacle corrected visual acuity, then we can offer Phakic IOL as an option. If patient cannot see clearly with the specs, then with IPCL also they will not be able to see clearly. So in those cases, the scleral contact lenses are better, or we may have to do some corneal procedure in that case, like the topo guided PRK or something like that, or intacs maybe. But if the spectacle corrected vision is fairly okay, then we can go ahead with the toric IPCL. And one more consideration here is that cornea is very steep. So if you use the same keratometric power for calculation, generally the calculator will give very large IPCL size. But actually it is a acquired steepness of the cornea, where the steep cornea doesn't mean white to white is more. So we have to slightly undersize the IPCL in these cases. Another thing is the patient, if patient wants to use scleral contact lens after IPCL, then if you are using a toric IPCL, after using scleral contact lens, patient will require a cylindrical spectacle for better vision, because whenever you use scleral contact lenses, it will negate all the astigmatism that is in the cornea. So whatever the cylinder is there in the IPCL, it has to be corrected by spectacles. So sometimes what we do is that if patient is planning to use the scleral contact lens after IPCL also, because with scleral contact lens, the visual quality is better than only with IPCL. In such cases, we can just do spherical IPCL and give glasses for the residual, so that when the patient uses scleral contact lenses, he doesn't have to wear any specs. Okay, so these are the important things you have to watch. So this is IPCL which has been enclaved. Like, we have to push it under the iris, and then generally the technique that I use is passive visco wash, where I don't use any coaxial or bimanual IA, and flush out all the viscoelastic from the antechamber and little bit from behind the IOL through those small holes which are there. So this is a very high cylinder IOL. So you can see that there is a central lenticle. So central part of the optic is smaller than the entire size. This is to reduce the thickness of the IPCL that is done. And scotopic pupil, you have to check up to 6.5 is okay. But if it is very large, like 7 mm, then we can order a customized phakic IOL, which has a larger optical diameter, so that patient doesn't get post-operative glares.
Yes.
Okay, any doubts? Anyone?
Sir, in keratoconus patients, supposing we are doing C3R before ICL, how long we have to wait after C3R?
After C3R, we have to make sure that the cornea is stable. So we have to take consecutive visits, check the refractive error. So at least 3 months will be needed. Okay. Sometimes some surgeons wait for 6 months. But the thing is, basically, you need a stable spectacle correction to order any phakic IOL.
And keratometry measurement should be done after how long after doing ICL, after doing C3R? Like
So
the final value.
for the first month, we don't consider any procedure. So at the end of 1 month, we can do the repeat scan. Then we have to repeat it after say 3 months. Check if it is still the same, if it is stable. If the topography is stable, then and the spectacle power is also stable, then we can go ahead with the phakic IOL.
Thank you.
When do you suspect keratoconus in OPD? Neha,
So when the keratometric values firstly differ, we do a topography. Uh,
what keratometric values?
if the keratometric values are difference of like 3 or more than
3 and 4, what cylinder?
keratometry value of K1 and K2 differs by 3 or 4 factors, then we check for the topography.
At
And
what
by
age? Patient is 60-year-old. Patient has 4 cylinder, corneal cylinder. Okay. Basically, in younger patients, if you have high cylinder, then and specifically if there is increase in the cylinder for last 6 months or so, we should do topography. Okay. Second thing is keratometric values. If the keratometric value is above 47, even the cylinder is less, we should rule out keratoconus. Many patients have form first a keratoconus if the keratometry is more than 47. Okay, so in those cases, we have to do pentacam. Many times we get young children with cylindrical powers. So in such cases, it is better to do topography and also check the corneal thickness. So if the corneal thickness is less and patient has high astigmatism with steep cornea, we should follow them regularly because they may develop into keratoconus. And in children, keratoconus progresses quicker. Also, patients with allergic conjunctivitis. So, patients with allergic conjunctivitis who rub their eyes frequently, that is most common cause for secondary keratoconus. So, that has to be checked. So, those patients with VKC, allergic conjunctivitis, when they come for visit, what are the things that you want to check in those patients? Neha?
uh, so mostly we have to see the time duration from where the patient is having these complaints. Are they recent or chronic ones? And uh, if the patient has any spectacle refraction is there, then we can check if there is a difference in any number. And
Two things we have to check. One is intraocular pressure because many of these patients on low dose steroids and some of them are steroid responders also. So that has to be checked every visit without fail. And second is corneal examination to look for any secondary keratoconus. These two things we have to check apart from any change in the spectacle correction. Also, specifically, we have to ask the parents to see to it that the child doesn't rub his eyes. So many times the redness and everything goes away, but sometimes children have a habit of uh, rubbing the eyes, or sometimes there is a mild conjunctival allergy which continues. So the main treatment, the main aim of purpose of treatment in case of allergy conjunctivitis is to resolve the symptoms, including eye rubbing. That is the main purpose of treatment. We are not going to cure the allergy in children, particularly VKC or even seasonal allergies, which go away with time only. But we have to control the symptoms so that there are secondary effects of that, like severe dry eye, corneal opacities, keratoconus, scarring, etc., are not there. And also, we have to avoid medicine induced complications like mainly glaucoma and cataract.
Yes.
So, what will you do if a child, say 7-year-old child, history of allergic conjunctivitis and self medication he's putting, the parents are putting steroid drops, now comes with posterior subcapsular cataract and raised IOP. So, how will you treat this child?
So uh, we can give a short-term anti-glaucoma course if the patient is having very raised IOP, and after that we can have an OCT to check if there is any. There,
Okay. So, first you will control the IOP.
yes.
We may wait for some time to see whether it is the steroid induced IOP goes down or not. What about cataract? What will you do for cataract? For cataract surgery, what will you do? Which IOL you will use this patient?
Use of hydrophilic or hydrophobic, I don't know, this patient.
We can use either monofocal or we can use extended depth of focus IOLs, and may require toric also based on the astigmatism in these patients with allergic conjunctivitis secondary cataract. Many of these patients also have quite advanced glaucoma, so may need trabeculectomy also along with the cataract surgery. Okay, what to do if the patient is steroid responder and still patient continues to have allergy? What will you do in these patients?
Sir, anti-glaucoma medication for it can be extended
Not
for
not
time.
glaucoma. I'm talking about just allergic conjunctivitis who are steroid responders. Now
Uh,
IOP is controlled after stopping steroids without any anti-glaucoma.
cyclosporine.
Shishir, what will you give?
Like cyclosporin and even calcineurin inhibitor like tacrolimus ointment given, sir, to control the symptoms of allergic.
Right. And how long does it take for its effect to be there?
Sir, it is
Say 6 months, up to 6 months.
Up to 6 months it has to be given, or
It will
effect takes
start its action uh, for up to after some 3 to 4 months.
months. No, no, not that long. Usually it starts action after 2 to 3 weeks only, but peak action may take 2 months to have. And we can continue these drops without any break for 6 months, up to 6 months.
Okay,
Okay,
sir.
but after 6 months, we may try to give a drug-free period for some time. And if required, again, we may have to start the medication. So the cyclotalamus ointment has a issue of irritation. So some children they do not allow Thalamus ointment to be put. So how do you prescribe it?
Now on the eyelid skin. Can apply it on
Nilambika?
the eyelid.
Nilambika?
So applying it on the eyelid skin
At night time.
at
Right.
night.
So it keeps on getting into conjunctiva. So that is one way to apply Thalamus ointment. To it also reduces the irritation while applying. Okay, and enough lubricating drops have to be given so that the symptomatic relief is there because we cannot give steroids. So in such cases, for soothing, we have to give lubricating drops or even ointments at times. Okay, some children may also require systemic anti-allergic medication like Montelukast, etc. So these children also may have other allergic symptoms like rhinitis or pharyngitis, allergic. So they may need a ENT consultation for taking care of those allergic symptoms. Okay. Next time, make a better presentation. I think this was not adequate. It should have all the details. We already have so many videos and presentation on the YouTube also, and there is so much recent data on Phakic that should be added. Okay.
Yes, sir.
Okay. We will end the
Thank
meeting.